Committee, IMA, I welcome all the participants. I especially thanks to our Dr. Vijayalaksmi, sir, first president of the IMA, Chairman Vijayalaksshmi SESHADRI, and Dr. Bal Imandar, along with all the panelists, starting from Justice Pratibha Singh, Professor Indranil Datta, Professor Subhash Vishwas, and my very dear and dynamic moderator, and also the Erika Patel, who is doing everything for last 2 months. I am proud of her as a chairman. And lastly, Meenakshi Deshpande. So I'm not without wasting time. It was safe. We have to save ourselves. Let's start. I allow you to start this program. Thank you very much.
Thank you, sir.
Thank you.
I welcome all of you to the third day of Safe Motherhood Week. This is an initiative by IMA along with Women Doctors Wing and Mission Pink Health. We are going to follow it for one whole week. I'm going to start with a small IMA prayer. May everybody be happy. May everybody be healthy. May everybody be free from pain, and may everybody be free from sorrow. May we be the healing cure beyond every greed and lure. Flag salutation. We, the members of the Indian Medical Association, stand here to salute our national flag. Its honor and glory shall be our light and strength, and its course shall be our course. We pledge our allegiance to it and realizing our responsibilities as the accredited members of this national organization. We swear we will dedicate everything in our power to see it fly high in the committee of nations. Jai Hind and long live IMA. I would like to take this opportunity to welcome Honorable Justice Pratibha Singh. Thank you, first of all, Madam, to come here and share your wisdom with us. We are very, very grateful that you have taken out this time to come here. Honorable Justice Pratibha Singh is a sitting judge of the Delhi High Court. She was a first rank holder from University Law College, Bangalore. She enrolled with the bar in 1991, and before being elevated to the bench, she was a leading intellectual property lawyer in India. The Pratibha Singh Scholarship, instituted in 2013, is granted to Indian students who have secured admission at Cambridge for pursuing LLM. She has also been awarded as the 30 Most Powerful Businesswomen in India award by Business Today Group in September 2018. She was elevated as a permanent judge of the High Court of Delhi on 15th May 2017. She has made significant contributions to the academic literature and legal developments in the Indian intellectual property law as a practicing lawyer and as an advisor to several legislative committees concerned with drafting related legislation. We welcome you, ma'am. Handing over it.
Thank you, Erika. Thank you.
I request everyone to mute themselves so that we can hear Madam very clearly.
I said thank you, Erika, for the kind introduction. Is it my turn to speak?
Yes, ma'am.
Oh, okay. I thought you still have something else to say. Okay. A very good evening to all the office bearers, the president, the secretary, and the dignitaries, my co-speakers, and all the attendees today. I first of all wondered as to why the IMA was inviting me. Actually, being a lawyer and a judge, I kept thinking, okay, usually I only attend legal seminars or intellectual property seminars, but it's very nice to be in a community of professionals, especially doctors, who've done so much during this pandemic. And I personally thank each one of the doctors and the medical community as a whole for the service that you rendered, not just in India, but across the world, for mankind during this very tough pandemic that the world is going through. Especially, I think the doctors, nurses, paramedical community in India deserves to be specifically credited, considering that you all work under such difficult circumstances as well in India and in personal difficulties as well. So thank you very much, and thank you one and all, including the members of the IMA. Today, we are here to speak about the Safe Motherhood Week, and Erika Patel has put in a full program which is being celebrated this week. Coming from the legal background, I must start by saying I always wanted to be a doctor. So I'm really happy that I've got the opportunity to be on a forum of doctors, if not being a doctor myself. And I would start by saying that, you know, in terms of the legal perspective in respect to motherhood, I'm sure all of you are very well aware of the various laws that India has, enacted to have safe motherhood for women. And these laws include, for example, the Maternity Benefit Act, which requires that pre-pregnancy benefits should also be informed to the women at the time of appointment. And then under the act itself, the maternity leave of almost 26 weeks is given. And there are several other benefits which are given. But there's one difficulty under the Maternity Benefit Act that I see, that this law is only applicable to those women who work in an organization which has a minimum of at least 10 employees. If 10 employees are not there, then the organization is exempted from the Maternity Benefit Act. And considering that a large number of women in our country work in the unorganized sector, I think this is a cause for concern, and we need to look into this. The second and the second enactment which I would mention is the Employee State Insurance Act, which gives insurance, especially for women who've had any sickness during pregnancy, miscarriage, or any other reason. So they are able to get the social insurance under the ESI Act. There are also legally guaranteed benefits which are given under the Maternity Benefit Amendment Act of 2017 for commissioning mothers. This is a very new thing. These are mothers who use surrogates or who fertilize their eggs for creating an embryo through incubation or any other manner. So they get a 12-week leave, and this is a very forward-looking enactment. And I think mentally, what the woman goes through, it requires some kind of, facility for such women. And I think that this is a very forward-looking and required amendment which has come in 2017. And as you're all well aware, surrogacy is also legally regulated in India under the National Guidelines for Accreditation, Supervision and Regulation Clinics in India in 2005. And there's a surrogacy bill of 2019, which is yet to be enacted in India. We also have, of course, the Prenatal Diagnostic Techniques Act, which prevents the, checking of the sex of the child during pregnancy. Now, insofar as abortion is concerned, I think India has taken a quantum leap recently under the MTP Amendment Act of 2021, which allows abortion until 24 weeks, and even after that, if there is any substantial fetal abnormality. I had the occasion to deal with one such case very recently, just about 2 months ago, where the mother was suffering from some cardiac issues, and she was on blood thinners. She had embryopathy, and after appointing a medical board, we were able to take a decision that she should be permitted to terminate the pregnancy even beyond the 24-week period. I think, again, India is one of the first countries in the world to legalize abortion under various circumstances. And considering that a large number of countries in the West are still debating it. I think, again, India has been very modern in its approach and pragmatic. And women are even given protection under the law. If they have miscarriage, they're entitled to 6 weeks of leave. And there are various other enactments, even under the provisions, even under the National Food Security Act of 2013, for the benefit of women. Various facilities such as creche and other facilities have to be provided. If a woman undergoes tubectomy, 2 weeks leave is permitted for women. Apart from this, even mothers, even women who cannot give birth to children are given protection under the Juvenile Justice Act, where single women can also adopt children, and they get leave even then to be able to, 12 weeks leave, to be able to take care of the child whom they adopt. So overall, there are a large number of enactments which do, protect women and enable them to have safe motherhood. There are two major concerns that I would like to highlight, being a mother myself of 2 children, and being in a family which has 5 children in a joint family. I do believe that, one area which requires some kind of a focus would be the mental health of pregnant women. And there's not much which is being said about that. We do take care of a large number of physical facilities, leaves which should be given, paid leave, unpaid leave, etc., which can be given to women. But I do think that though the laws which have been enacted take care of, for example, a large number of people who may be even from the lower strata of society or even from the lower middle class, among the even affluent class or even the middle class, I do see that a large number of young mothers have a lot of mental health issues nowadays. Apart from though they may have all the physical and financial facilities, and therefore there needs to be something more to be done in promoting the mental health of women and pregnant women and young mothers. As you all know, the postpartum depression is a very well-known phenomenon. But, in our families, I do believe that culturally, we do have an issue in generally recognizing mental issues, and especially even in pregnant women. There is so much hormonal change that a pregnant woman goes through that right from the inception of pregnancy, the woman undergoes a large amount of insecurities, mentally, physically, and within families, this is not so acknowledged and recognized. So I think that the IMA could, start some programs which is meant to, sensitize maybe older women in families. I don't know how we are going to do this. It is going to be a little challenging, like mothers and mothers-in-laws and, that kind of generation needs to be educated on mental health of their daughters and daughters-in-law and how they need to be taken care of during pregnancy and even after having a child. And, I remember very clearly when I had my daughter, she was very colicky for some reason in the first 2-3 months. And the first outing I could take after the 40 days was like a big break for me. I said, okay, this is my big break and I want to use it. So there is so much insecurity that a young mother goes through. And this is very important because as long as mothers have to be healthy mothers, not just physically, but also mentally, and some importance needs to be given to mental health of mothers. That's one focus point that I wish to mention. The second point I wish to mention is about all these laws. While I understand that these laws are important to safeguard the rights of women, the rights of pregnant women, rights of lactating mothers, rights of single mothers who want to adopt children, sometimes I do get the feeling that these laws may actually be dissuading employers from employing women. So if this situation is there, how do we strike the right balance in this? Because if an employer gets a choice, all things being equal, between a woman and a man, I do feel that these laws may dissuade the employer from taking the woman into employment. So do you think that we are over legislating? Do you think we need to give more freedom to employers and keep it more flexible, make it more weeks for work from home, and allow women to have their own flexibility? And if we do that, I think we may be encouraging employers to employ more women. And we don't want a situation where there's so much over-regulation that women don't get employment. And we don't want that kind of a situation. So are we over-regulating? Maybe we should debate it and sometimes maybe provide for more flexibilities in this area as well. So I think I'm crossing my 10-minute time period. And I thank you all for calling me on this platform. I really wish this whole event, which has been put together with so much enthusiasm and so much forward-looking thinking, especially during the pandemic without meeting each other. I think it's a good opportunity for a larger audience to take part in an online virtual audience. And I congratulate the organizers, the IMA, the president, the secretary, and all other office bearers, and Dr. Patel, who has taken so much effort into putting this together. I thank you all for calling me today, and thank you very much, and thank you for listening to me patiently as well.
Thank you so much, ma'am. Like you asked at the beginning of the lecture that you did not know why IMA chose, this is exactly why we wanted somebody like you to come and address us. It is so important for us gynecologists also to know all the laws that are existing, because I'm being very honest, I myself did not know one or two of those laws. So it is so important that we get ourselves educated about how we can help women when they are pregnant, in their postpartum, and in their careers as well. So thank you so much for...
Thank you. Thank you very much.
Thank you, ma'am. I move on now to introduce my chairperson, Dr. Vijayalakshmi SESHADRI, MS, FICOG, FIC, MCH, and CIMP, Senior Consultant, OBGYN, Sundaram Medical Foundation, Chennai. She is the president of the South Indian Obstetric Gynec Society, Executive Committee member of Tamil Nadu Federation of Obstetrics and Gynecology, member of the Quiz Committee member in IMS, Breast Committee member in FOXY, past President, Chapter Secretary IMS, Constitution Committee member of ISOPAB. She has won the Best Paper Award in AICOG Patna. She is the chairman of a research committee in IMS also, and her special interests are high-risk obstetrics and midlife health. Welcome, ma'am, and thank you so much for accepting to chair our session today. Our next chairperson is Dr. Balkrishna Inamdar. 38 years experience in gynecology, diploma in pelviscopic surgery from Kiel University, Germany. He's the author of many books, including ABC of HIV/AIDS and Rural Development, A Rotary Perspective. He was the Vice President of the Indian Medical Association, Maharashtra State, past IMA National Chair for Safe Motherhood, President IMA Mumbai West for 2010-2011. Welcome, sir, and thank you so much for joining us today. Over to you, ma'am.
Good evening, all. So,
sir.
Dr. Bal Inamdar, would you want to say in the beginning?
Yeah,
anyway, from my bottom of my heart, I thank the entire IMA family to have invited me for this particular webinar. I know you are running a very good webinar through the week. All the best. And I'm really thankful to Dr. Erika for being in continuous touch with me since the time she has invited me. And so I could get a very good glimpse of this entire program. Anyway, I'll first hand over to Dr. Bal Inamdar, my co-chairperson, to carry on with the first talk. Dr. Bal.
Thank you, Dr. Vijayalakshmi. Let me echo your sentiments about this seminar and this webinar and Dr. Erika. They both are absolutely marvelous and deserve a lot of compliments. Past President Dr. Vinay Agrawal, I can see him in the audience. Dr. Datta, who is the chair of the Safe Motherhood Committee. Dr. Erika, who is a convener. Dr. Vijayalakshmi, who is a chair of this particular today's webinar. Faculty members and others who are present in this great webinar. Let me first introduce Professor Dr. Indranil Gupta. He is MBBS, MS, and with numerous degrees. He has had advanced laparoscopic surgery from Kiel, just like even I had gone there, and a cosmetic gynecology from American Aesthetic Association, a fellow of USG Fellow Endoscopic Surgery. He's a professor at Medical College IQCT NH Durgapur and immediate past president of KOGS, which is a part of FOXI. He's an ex-member of YTP committee of FOXI and past East Zone coordinator for under FOXI president. He has been an IMA standing committee member for antimicrobial resistance. He has published so far 40 articles in various index journals. Articles and repute include PubMed database and Cochrane database. What is important is that he has also written personality with a distinguished biodata. May I invite Professor Dr. Indranil Datta to speak on prevention of maternal mortality. Dr. Indranil.
Yeah. Thank you, sir. Can I share my screen now?
Yes, sir. Please go ahead.
Okay, so is it visible? So I'll start now.
Yes, sir. It is visible in full screen.
So thank you very much, organizers. Thank you very much, Erika, for giving me this opportunity and organizing this wonderful program. And with the blessings of all the seniors and all the learned members, I will start my presentation. So basically, my topic is a very important topic. It has been a very important topic for years to prevent this maternal mortality. Maternal mortality has been the hottest topic even in all the organizational meetings, IMA meetings abroad, wherever we have gone. So India has come a long way in this, and India has long evolved. Like few years back, we still remember this particular slide, 2007, published in Deccan Chronicle, that approximately a mother dies every 7 minutes. But I'll give you some positive points out of this thing. Basically now, if we see now, there is a healthy trend. The MMR rate has considerably reduced, particularly due to the help of organizational people like IMA, FOXI, and also with the help of the grassroots level doctors, the healthcare workers, the ASHA workers, everyone has been involved in it to reduce the maternal mortality rate and the ratio. It has come down. The recent report which has been suggested, this is a very recent article which was suggesting that India has registered a steep decline in maternal mortality ratio. That is a very good and a positive note. But still we have to keep doing a lot of things. Recently, very recently published in February 2021, it has suggested by the sample registration system, that is by the Registrar General of India, that the last recorded MMR rate was in 16 to 18 was 113, which is considerably good considering the way it is dropping. But there is some problem with this particular distribution among the states. Now, as you observe, if you observe in the last line, you can see 113 is the maternal mortality ratio. But if you come to the individual states, there are some states which are actually lagging behind, yet they are lagging behind. Like coming to the state of Assam, where it is 215, compared then coming to the state of Madhya Pradesh, 173, and henceforth. Now coming to South India, the performance is much, much better. So there are a lot of factors to this. There are a lot of factors. We will go through the factors. This is not a forum to point out the faults and the mistakes. In a whole, we have to think about India, and India is doing better. Now coming to the main causes. Yeah. So basically in Asia, it has been found that it is the hemorrhage which is the main cause of problem. Hemorrhage is the problem in our country, mainly due to the lack of the facilities in the rural area, or maybe due to lack of transport or lack of awareness, a lot of things. Compared to the developed countries where the other direct causes which are mainly responsible, it is not the hemorrhage. Maybe hypertensive disorders, maybe other disorders. So problem with our country is only the hemorrhage, which has to be taken place, which has to be taken care of on an urgent basis. So what is common? They all are preventable to a great extent. Whatever causes I have shown here, they are all preventable to a great extent. If they are all preventable, then why not we are able to do it? Why not we are able to do it? Because there are a lot of factors in our country. It's a huge population country. There are social factors, there are economical factors, there are medical factors. Quickly going through the social problem. The problem in our country, early marriage. Early marriage means teenage pregnancy, more chances of teenage going into hemorrhage, conceiving very early, leading to a lot of problems in these women. Gender discrimination, illiteracy, desire for selective sex or female feticide, domestic violence, we know it exists in our country. Economic issues like lack of money is again one of the biggest issues in our country. Improper dietary habits, lack of antenatal care, lack of emergency obstetric care, lack of blood and blood products. This has been talked all through last 15, 20 years, how to reduce MMR, but these are still one of the biggest problems, particularly in the rural area. So how do we prevent? Now the question which I'm talking about. So health education. So age of the marriage, this has to be taught, that age of the marriage has to be deferred, or even if married early, the woman should take contraception early and then try to get pregnancy later on, not very early. Do not try to get pregnant at the age of 16, 17, 18. This has to be put into the mindset of our population. Utilization of the services provided by the government, awareness of antenatal care, nutritional education, importance of immunization. Safe abortion services. The problem, again, another taboo in our country is, suppose a woman becomes pregnant, unmarried woman becomes pregnant, it becomes a taboo. They go to some places where they want to do abortion at not a very legalized procedure, which leads to a lot of problems leading to maternal death. So this has to be taken care of. Health delivery infrastructure, like provision of RCH, that is reproductive child healthcare services at remote areas, is again important. Improve staffing at the remote areas. Healthcare deliveries like emergency management of eclampsias, emergency management of postpartum hemorrhages has to be taken care of, particularly in the rural outset. Adoption of small family norm. Again, this is a very important topic in our country. So how do we prevent? So again, prevention is, we have to prevent anemia. If you prevent anemia, you go into the direction of preventing postpartum hemorrhage. The concept of 100 tablets come here, which has already been advised the government. Non-health strategies like poverty eradication, improvement of literacy, we all know these are important factors. So what are the policies which we can adopt? Legislative and policy actions has to be taken. Society and community plays an important role, and health sector has to be involved. We know there are a lot of acts, the MTP Act, the Sharda Act, the Janani Suraksha Yojana Act, which was very powerful and very successful. Adolescent Education Act, decentralization, and certain protocols which are given time to time by the appropriate authorities. This has to be enacted upon. So what is the role of the society and the community? Mainly the national, regional, and district safe motherhood committee should be set up. Health facility and community programs should be conducted at remote areas also. Addressing particularly certain diseases like STDs, RTIs, hepatitis, malaria, particularly at the grassroots level. Preventing unwanted birth mainly is the most important thing which has to be put in the mind of our people. So health sector, when we come to the health sector, the medical sector, antenatal clinics, skilled birth attendants, postnatal care, abortion services, EMOC services has to be implemented at the grassroots level. So first level antenatal care, particularly birth, which has to take place in the tertiary care center, has to be organized and has to be made sure. Ideally provided in the hospital, birth should take place in a hospital where doctors, specialists, skilled general practitioner, mid-level technicians at least should be present to make a successful and a good delivery for a mother. There are a lot of programs which has been enacted, as I told earlier. Some of the programs I'll just go briefly, like which requires basic registration of the pregnancy. Every pregnancy should be registered irrespective of weeks of gestation. It has to be a centralized process so that the follow-up is easy. At least 3 prenatal checkups are advised. Assistance during delivery, that is skilled birth attendants, and at least 3 postnatal checkups. These should be the part of the way how we treat our women, particularly in the obstetric care. Emergency obstetric care, particularly 24-hour deliveries at the PHC and the CHC level. Referral transfer to through the panchayat. The panchayats also should be involved in our thinking forward. Blood supply, most important, the blood banking, the blood supply, particularly to the PHCs and the first referral units. These are the units which require the blood supply because people are dying for the lack of blood when they are being transferred to other higher centers. MTP services has to be again made modern and made available to the poor. We all know Janani Suraksha Yojana. Just to go through it, it is basically there are 2 parts: the low performing states and the high performing states. So according to that, the mothers are given some amount and the ASHA has been given some amount so that the delivery becomes a process which is regularized among the rural population so that they are incentivized to attend the tertiary care center. Particularly for the low group states, the government has taken certain has given certain additional benefit, like age restriction is removed and restricting benefits of JSY up to 2 births has been removed. There is no need for marriage or BPL certificate. These are the certain changes for the low performing state because there was low outcome of this program there. VANDE Mataram scheme was one of them, where the Foxy and other private clinics had a public-private partnership, which again helped in this regard. And we know there are a lot of challenges. The challenge basically on establishing the database on maternal mortality, high-risk pregnancy behavior, too early, too many, and too close number of pregnancies, urban and rural divide, poor rate of institutional deliveries, lack of skill care at birth, poor implementation of program. All these are acting as a hindrance in our target of reducing this maternal mortality. But we all know when there is a problem, there is a solution. And what we think, there are certain points, 10-point action, which we can follow, like advance safe motherhood through human rights, empower women, ensure choices. Safe motherhood is a vital economic and social investment. Delay the marriage and the first birth. Every pregnancy faces risk, so ensure skilled attendance at delivery, improve access to quality reproductive health services, prevent unwanted pregnancy and address unsafe abortion, measure progress, and maintain the power of partnership. So we follow in our place, what we follow is 3 steps. This is probably the second last slide. So in step 1, crisis, every woman should know about the crisis or the problem that they may face in their life from pre-reproductive period to post-reproductive period. Step 2, care. Having knowledge about the crisis, that is prevention, should be instituted to protect against childhood and adolescent health issue, to prevent complications of pregnancy through early detection and treatment, to provide clean and safe delivery, to promote the implementation of family planning program and predicting the early diagnosis of post-reproductive disease, 100% encouragement of institutional delivery. And step 3, cure, that is immediate action has to be implemented to promote action and management of puberty and adolescent program, and to diagnose and manage the complications of pregnancy, and to ensure the immediate step to prevent third stage complication. With this, I would like to end with this message that childbirth is a miracle of life and it should not become the nightmare. No one should face the nightmare of death. The mother should not face it. So with this, thank you again to all the leaders of IMA for giving me this opportunity. And thank you, Erika, for considering my name. I'll stop the sharing of slide.
Wonderful, Dr. Indranil. Precise and concise and to the point. So, Dr. Erika, we should take some questions now, or should we be afterwards?
Sir, you can go ahead with your
Okay.
screen and then we can take the questions.
Okay, so let me now share my screen quickly. Piyush, can you allow me to share? I can't share.
Yes, sir, you are allowed.
Yeah, thank you. What I'm going to share with you is something which is apart from the usual thoughts that normal gynecologists would talk about. And this is something called as, all of us, we know about 3-delay model. And all of us, we know about how to reduce maternal mortality. A lot of us have worked a number of times on this. But this is a point which probably in those areas, which are remote areas and those areas where maternal mortality is still high. And I'm so very happy that maternal mortality is now touching our original millennium goal of 109. It's 113, but some of the states is 65. So that's very nice. Let me quickly go through this. It's estimated about 300,000 women die annually due to maternal causes. But the problem is we currently do not have, we have only estimates. We do not have the truth of what exactly is the reason why some of the countries have. Almost more than half of the world's deaths pass by undocumented. It's a major concern. And that leads for us to understand health planning. What is important for maternal mortality is out of all these countries, only 65 countries have a complete data. 88 countries lack complete data, 27 countries have no data, so 80% of countries do not have actually the data as to the reason why maternal mortality takes place. And that is a very serious consequence. And obviously, if we don't know, we can't prevent. And our major, now that Indian Medical Association and now that India is racing towards its lowest ever maternal mortality rates, time has come probably for us to look at those who are disadvantaged states and those who are disadvantaged countries like Nigeria. And I would definitely like Indian Medical Association to look at it, because if we are skillful, it's important for us to pass on these skills to this. So effectively address, we first need to find out what women die from. And that is a very crucial point. It needs political will to achieve minimum set of vital data, and only then we can see, understand how to address the reasons why maternal mortality really takes place. And obviously there is a R&D involved, because this is essentially a digital data which needs to. And there are a number of ways we can collect this. The reason that then the reasons can be accumulated and given. Better data means obviously designing better interventions, monitoring maternal mortality trends, and accounting for different deaths. That's better maternal health. Now, has it been done? In Nigeria, one of the highest maternal mortality rates, about 800 plus, and we are happy that we are about 130. Why I'm giving this example is that it's important for us to realize the 3 states in Nigeria, they went under, along with German Health Department and Nigerian Health Department and Nigerian Medical Association. These 3 came together, and 3 states, Lagos, Ogun, and Oyo, these 3 states, what they did is that every healthcare facility was provided with digital connectivity and internet. And this was all centralized at a server in Nigerian Health Department. In these 3 states, after this, when they realized the reasons why maternal mortality is high at 800, they addressed these causes. And you'll be surprised to know that in only these 3 states, now the project is getting over, in these 3 states, maternal mortality is reducing by almost 50%. Now that's a significant change which is taking place. I was at one of these places. On the left side, you can see they call as TBAs, the traditional birth attendants, and most of the deliveries they take place in the homes. And now they have changed. And this is what I wanted to say, that it's important that while we concentrate on reasons for the deaths, actual reasons, the hands-on reason for death, it's important to realize that there is at back end, as Dr. Indranil also mentioned in one of his slides, that the collection of data for the reasons for this is also very crucial. Thank you so much.
Thank you. Thank you, Dr. Bali Namdar, for such a nice illustration and summing up after Dr. Datta's talk. Very, very informative talk by Dr. Datta, and following that, a very good comment along with the slide presentation by you. Thank you so much. Now, I think, in fact, I was wanting to thank the Honorable Justice Pratibha Singh ji also. Such a powerful introductory talk she did. We are all aware of lots of acts which are going through for the safe motherhood, but still to sum it up and then also looking into it from a medico-legal point of view as well as from the medical point of view, and trying to find where there could be some lacunae, can we fill it up. Such a nice introductory talk by Honorable Justice Pratibha ji. And now, when Dr. Datta was talking, I was remembered of the senior Dr. Dilip Datta. I think for several years, I have heard him on the prevention of maternal mortality. He used to present from Kalyani. And am I right, Dr. Datta? I think he's gone somewhere. So that was a wonderful presentation. And we are all, I think, we have a lot of target working towards the prevention of maternal mortality. Thank you so much. So now we move ahead and go on to the next presentation, again to a very important topic, the anemia in pregnancy. We are all very much aware how much of morbidity and mortality it causes, and also a lot of hidden anemics. That is what when we discovered during pregnancy, and how they have impact on the maternal as well as the fetal health. And to tell about this, we have Dr. Subhash Chandra Biswas from Kolkata. He is a past president of the Bengal Obstetric Gynec Society. He has been the national editor for the Jogi. He's been into a peer reviewing for several national international journals, and he's also Secretary Board of Studies, the West Bengal University of Health Sciences, and lots of publications to his credit. So over to you, Dr. Subhash Chandra Biswas, for a very important topic of anemia in pregnancy.
Thank you, Madam SESHADRI, for your kind introduction. It's nice to be with you, because so many foxy conferences actually we made, but during this pandemic actually we have lost. And my heartiest gratitude to Dr. Bal Inamdar at the same time. First of all, I should express my gratitude to the Safe Motherhood Committee of IMA, including the IMA President, Secretary, and all organizers. But special thanks to Professor Dilip Datta and Dr. Erika for including me in a very interesting and nice session. And my beloved Indranil has already focused on maternal mortality, and he just emphasized one of the contributors is anemia. So I am to talk on anemia. Anemia is very important. May I just share my presentation, Indranil? we going to go to the there is some problem with how can I go to the beginning actually?
Yes, sir. Just right click on the screen.
Right click on the screen.
Yeah.
Yeah,
And you can get an option from.
it's not showing. Yes, so how can I go to the first slide? See all slides? Or
Yes, click on see all slides and select the first one.
um, can I go to the first slide?
Yeah, just scroll to the top.
No. Suddenly it happened. It's not like this. How can I go to this?
See, there's a left arrow on the top left.
Where is that? Yeah.
No, after you select see all slides.
Really a problem.
Okay, just end the show now.
Then I go to the end show.
Yeah, end show. Press escape button on your keyboard.
Yeah. Even it's not coming.
It will come here.
Okay, let me check.
Okay, scroll to the top here. Select the first slide and then do a slideshow.
Then yes. Very
Alright.
sorry. Just I am really very sorry for this interruption. So I am to talk on anemia in pregnancy. This is very important topic as Indranil has already raised the issue. It is one of the contributor of maternal mortality. But how can we define? It is a condition where RBC or its quality leads to oxygen carrying capacity insufficient to meet body's physiological need. And WHO guideline has just outlined in pregnancy, the hemoglobin level should be taken at a low level to stamp it as anemic. In first trimester, the normal is taken up to 11. Then in second trimester, it is 10.5. Third trimester, again higher 11. And that is categorized again into mild, moderate, and severe. Severe one is lower than 7 and moderate is in between 7 to 10. So anemia in the postpartum females is defined as hemoglobin less than 10. So we should know the level, otherwise we cannot stamp it. And that's the reason the statistics become very dubious. Because the exact statistics is not available, what we see is nothing but tip of the iceberg. But global prevalence, you see, 25% of the people of the world's population are suffering from this, of which the 56 million are pregnant women. Anemia affects up to 75% of pregnant women as per WHO in 2016. Anemia is not only a contributory factor of maternal death, but also an aggravating factor in hemorrhage, sepsis, pregnancy-induced hypertension. You see this globally. India is suffering from anemia much more, and that is shown by the red area. And it is as high as almost 80% in pregnancy sometimes, because the physiological changes causes disbalance of iron in a female body. That is obligatory iron loss and the increased red cell mass for the mother, for the newborn, as well as the tissue which is arising new in the pregnancy, that is the placenta, umbilical cord, and the plasma volume expansion. All these will lead to increased demand, though there is some saving in place of menstruation. But even then, the extra amount is needed is about 600 to 800 milligram. So the increased demand of iron is 9 times higher than the non-pregnant woman. So the cause may be physiological, as I have outlined, and at the same time there is the increased demand may be due to multiple pregnancy or some other condition, diminished intake of iron as the mother is suffering from anorexia and vomiting, and other pathologies like nutritional deficiency, hemorrhagic cause, hemolytic cause, or hemoglobinopathies. But the symptoms, as in case of non-pregnant women, it is the same. Everyone knows it. But the symptoms and signs of iron deficiency, anemia in pregnancy are usually non-specific and just mimic normal pregnancy changes. That I want to highlight. So you don't take it as physiological. You have to investigate the case to find out the severe anemia. Consequences of iron deficiency anemia in pregnancy, it affects the mother and fetus both in antepartum complications that increases the risk of preterm delivery, PROM, preeclampsia, intercurrent infection, even antepartum hemorrhage and congestive heart failure. Interpartum complications are prolonged labor, increased rate of operative delivery, then induced labor or fetal distress, as well as the postpartum complication like PPAs, peritoneal sepsis, pulmonary embolism, thromboembolism, some embolization, and ultimately the fetus born will have low birth weight, prematurity, infection, congenital infection, neonatal infection, and all. So the maternal mortality, as Indonil has just highlighted, the direct cause contributes in 20%. But indirect cause also another 20%. So it is as high as 40 to 50% of the cases, it becomes a silent killer. How to diagnose anemia? Apart from this symptomatology, both symptom and sign, we have to go for investigate the case. The investigation starts from serum iron level, ferritin level, very important, as well as the saturation of trans-ferritin. But these are the two parameters we should not ignore. If it is iron deficient only, not leading to anemia, then it starts falling, as well as the ferritin starts falling. When the mother is having anemia due to iron deficient state, then the serum iron is drastically diminishing and the ferritin level goes below 12 microgram per deciliter. And that has to be differentiated from other acute causes of anemia or due to other chronic diseases. That has to be differentiated by other investigations like this beta thalassemia, sideroblastic anemia, or other chronic disease. That has to be differentiated by ferritin level, serum iron level, total iron binding capacity. These are the very important part. And as well as to stamp its really iron deficient state, this RDW and the reticulocytes count, these are very important parameters. Serum ferritin level in pregnancy itself initially rises, gradually falls by 32 weeks, followed by rise again in third trimester. But fall in serum concentration below 15 microgram per liter definitely indicates there is depletion of iron in the body. In the indications of doing this ferritin level, prior to starting any iron therapy, be it oral or be it your particularly parenteral iron therapy, we have to stamp it really it is iron deficient state, not with other causes like hemoglobinopathies. When an alternative etiology has been thought of, then you have to do it. And the suboptimal response to oral iron therapy, and in non-anemic women at increased risk of iron depletion, in that case also you have to do it. Other investigations are peripheral blood smear, very simple. With good pathologist, you can do it, look it whether microcytic or hyperchromic or the macrocytic anemia, and stool urine should be done, particularly in our tropical country. Then followed by other causes like tuberculosis, and everything can be excluded by X-ray, but that should be guarded in case of pregnancy. Other special investigations, that is according to the case itself, how to manage iron deficiency anemia, how to prevent and how to treat. The prevention strategies by WHO, it should be food-based approach. Don't forget, the food is very essential part, followed by iron supplementation and improvement in health services, sanitation and control of all these problems like hookworm, malaria, parasitic infestation. We should not forget in the rural India. Dietary modification and improvement should be in the line of what enhances absorption, like what are the diet which will enhance absorption and what are the diet which will inhibit absorption. That is very important, so that will lead to high bioavailability of the prescribed or the delivered iron. That's the reason we should need to know all these things. So we should take the vegetables, and it is said that the daily take at least 5 different colors in diet. That will give the iron in different form to absorb better. Prophylaxis of iron deficiency by WHO in 2016, they have just recommended supplement the iron by 30 to 60 milligram of elemental iron with folic acid 400. But Government of India recommended that 100 milligram of elemental iron with folic acid 500 microgram. That is very important. Indonesian also highlighted the 100 tablet for any pregnant woman. The frequency on supplement daily is usually recommended both by Government of India and WHO, and duration throughout pregnancy starting from 14 to 16 weeks, this 100 tablet, including few days in the postpartum period. And all pregnant adolescent women or females should be targeted. And total supplemental iron intake per year is about 5,200 milligram of elemental iron to combat anemia. Modalities of treatment, apart from the diet and the dietary advice, we have to supplement by iron, by oral preparation, parenteral preparation, or in certain cases, blood components or blood transfusion. So there are many iron preparations, but we should think of the elemental iron constituent of the salt it is given. Now, how much percentage is there in the supplied salt and how much is going to be absorbed. Not only the high content in carbonate iron, and that is claimed by the pharmaceutical companies. Though it's very good because there is a high component of iron, but how much is getting absorbed? Only 5 to 20%. So we have to choose something which has got less iron but maximum absorption, and thereby increase the bioavailability. And the instruction is taking tablets on an empty stomach or 1 hour after a meal for better absorption, and avoiding consumption of the food which retard iron absorption. That is very, very important. And
Dr. Subhash?
there are papers. Yes?
You have
there
to
are papers. Okay, I'm just finishing it. There are papers whether you have to go for intermittent or daily iron supplementation. There are papers the intermittent iron supplementation is as good as the daily if there is side effects, the gastric side effects are more. So indicators of iron therapy response, mainly the reticulocyte and increase in the hemoglobin level as well as the epithelial changes apart from the hemoglobin concentration. Problems with the conventional iron is mainly the gastric upset. So non-compliance should be kept in mind, and you have to work upon how to improve the compliance by changing the preparation and the dietary habit. What are the latest oral iron preparations? Already I have told, but certain companies have come with these delivery system which are micronized and micro encapsulated iron. But always the absorption facility is different, but even the bioavailability may not be at its highest level. So when to stop oral iron therapy, that goes even the postpartum period, 3 months postpartum. When should parenteral iron therapy should be considered? This is very important. That I am taking some time. That failure to oral iron therapy to improve the conditions and non-compliance of the mother, late second or third trimester, particularly third trimester, the iron deficiency anemia is evident, or she is having some malabsorption, bleeding diathesis, there is not much time, moderate to severe postpartum anemia. Under those conditions, you are just keeping aside the contraindications, we should go for parenteral iron therapy. What is the status of intramuscular iron therapy? Is gone out of fashion. Even that has been told by Ministry of Health and Family Welfare. So we rely on intravenous preparation. The intravenous preparations are many. That is iron ferric carboxymaltose and iron sucrose. These are used for years together, and that is without much side effect. But even iron ferric carboxymaltose is now is coming up, and it needs approval by the ministry, and USA approved. The studies are going on. Even my 2 PGDs are doing, and there are other centers like Chaitanya Shivasadhan in Kolkata. They are doing. We have included many numbers. The results will be published very soon. So we don't feel that much problem with ferric carboxymaltose. Iron sucrose complex, calculating the dose as per formula was used for many years, but there are differences between this iron sucrose as well as the ferric carboxymaltose, because ferric carboxymaltose is a highly stable formulation providing controlled release of iron, low risk of acute toxicity and serious hypersensitivity reaction, no test dose required, and the large dose can be given at the same time, even up to 1000 milligram. Within 15 minutes it can be infused, and we don't have any sort of reaction which is detrimental to the mother, even to the fetus. So there are certain drawbacks. It is not approved till date, and the category C drug, but it's going to be accepted very soon, and it can be used in the pediatric population very soon, but not yet approved. So comparing the two, I have already discussed all these points. Treatment of iron deficiency anemia with intravenous versus oral iron. Yes, this is the study is undergoing in me, but the American Journal of Perinatology, they have also done, and they have highlighted IV iron is superior to oral iron for treatment of iron deficiency anemia in pregnancy. Women receiving IV iron more often achieve desired hemoglobin target faster with fewer side effects. So if there is iron deficiency anemia, according to the period of gestations, you decide whether you will give some time with the oral iron. If the time is short, then check the ferritin level and give all other vitamin supplement and go for your parenteral iron therapy.
Dr. Subhash.
When should blood transfusion should be considered? Just the last slide. We should keep in mind that the blood transfusion, whenever there is not much time and the hemoglobin level has gone down below 7, then we have to go for if the pregnancy is more than 36 weeks. Transfusion should be prescribed. So in those cases, when no other option can take it the faster, your course of action, and the liver monitoring should be supervised, and the intermittent oxygen should be given, prophylactic, antibiotic, and all other precautions as far to cut short the second stage and to deliver the placenta very quickly, that has to be taken into considerations, including advice during postnatal care and contraception should be advised adequately. So all these things have been highlighted by our Dr. Beloved Dilip Datta. Dilip has written a very good book on this, and that is going to be released very soon. He has mentioned all these things and also highlighted some of the cases. They're like sickle cell disease, thalassemia, hereditary hemolytic telangiectasia, autoimmune hemolytic anemia that need to be excluded when we are treating the case. So the myths, mild anemia does not have any great significance. Dietary modification is enough for treating the anemia. Baby will not be affected by mild anemia. Baby will grow black or big due to iron. Don't go with this idea. Iron injections are very dangerous. Don't throw it out. This idea. Delayed cord clamping results, increased phototherapy. So all these myths have to be discarded. Thank you all. Thank you for your patient hearing.
Thank you so much, sir.
Thank you.
We have, sorry, madam, for interrupting. We have our president, sir, here, Dr. Jailal, sir.
No problem. No problem. I know it's
Thank
very
you so much,
big
sir, for
topic
joining
now.
us, even when you're traveling, sir.
Yeah.
Thank you, Erika. It is a great initiative.
Yes, sir, we can.
Yes, thank you very much. I am so happy that so much of people are participating and you are doing it in an excellent way. I am really delighted, not only me, and their whole leadership, IMA is delighted to profit. Please go ahead, please.
Thank you so much, sir.
Thank you, sir.
I hand over to Dr. VIJAYALAKSHMI SESHADRI, again the president of the South Indian Obstetric Society, who recently received an award from the Chief Minister of Tamil Nadu's Mr. Stalin about her outstanding work on during COVID time. So congratulations, madam.
Thank you, but a lot of humility, I will submit that was on as President Oxy. So the whole credit goes to Oxy and Foxy. So I really thank every Oxyan and every Foxyan, and it was not my personal credit. And that was a very good function, well organized. In fact, IMA also received an award, Dr. Know it. So thank you. It was nice. The entire many awards were given by our Chief Minister, Shri M.K. Stalin. Very nice of him to have honored the doctors on this 1st of July on the Doctors' Day. Thank you so much, Erika, for mentioning that.
We will just move on to the next lectures, madam, since we're running short of time. We can take on the questions at the end. Yeah, no, the questions, answers, just one moment. I would like to say that more questions are being asked on the COVID-19 and vaccinations in pregnancy and lactation. The permission has come recently from the ministry. So guidelines have been now put on and we are going through, but I'm aware that this particular program itself, this IMA week, they are doing it on 6th, the last day, entirely on COVID. So I think more of those attendees who are eager can log in on that day, clarify all their doubts on the COVID-19 vaccination. Am I right, Erika? Yes, madam. Yes, madam. On 6th.
So we will move ahead. Yes. Sir, we will move ahead with the topic of the day. Next, Dr. Inamdar. I hand it over to Sir, my co-chairperson.
Yeah, thank you. And let me also congratulate you, Dr. Vijayalakshmi. It's a great honor for all of us that you have received award on behalf of Foxy and OC.
Thank you, sir.
The next topic that is going to be taken is by Dr. Erika Patel. Of course, she doesn't need any introduction now in National IMA. But what is important to realize that pregnancy is the only condition which is a physiological condition, and we always talk about treating pregnancy. We always talk about patients who are pregnant. The very fact that we designate a person as a patient automatically thinks that he's a diseased person, which is not the case. And if it's a physiological condition, then obviously two most important pillars on which this physiology is based on is diet and exercise. And hence we have to concentrate on diet and exercise because in principle, it's a physiology and not a pathology that we are tackling. And to this extent, Dr. Erika Patel is going to talk to us. She is one of the first few in India to have completed her MCH reproductive medicine and surgery with a gold medal. She has been an IVF specialist and she has received training from all over the world, Boston, Harvard University, Michigan IVF training. Here she has been trained in andrology. She is right now a consultant at fertility at ART Fertility Clinic in Chennai. But what is very interesting is that she is right now even pursuing PhD in reproductive medicine. Erika, all the best, and we wish you all the best on this. And obviously, all of us, we know that she is a national convener in the Safe Motherhood Committee. So she is going to talk on physical activity and exercise, probably one of the most important subjects for pregnancy. Because pregnancy is physiology, and all this is a physiologically addressed. Dr. Erika.
Thank you so much, sir. This topic is personally very, very dear to my heart because I myself went through a pregnancy during COVID time last year. I have a 1-year-old baby now. And I did continue my physical activity till the very last day of pregnancy. And hence, today I will talk about this with evidence-based medicine as well as a personal experience also. So the overview of this entire talk is I will talk about misconceptions. What is the anatomy and physiology? What are the benefits and risks of exercise? What precautions you should take? What are the best practices? This is based on the American College of Obstetrics and Gynecologists, which published an extensive guideline about exercise in pregnancy and how to promote safe and appropriate physical activities for all women throughout pregnancy. So you would have often thought of true or false. What is true or false? Regular physical activity during pregnancy may cause poor fetal growth, musculoskeletal injury, miscarriage, premature delivery. Do you think it's true? Do you think it's false? You hear so many things, so many people telling you. So when we talk about evidence-based medicine, there is no substantial evidence that women with uncomplicated pregnancy will have any of these complications. So despite a lack of clear evidence that musculoskeletal injury, so a lot of people say that if you do exercise during pregnancy, you will injure yourself. So despite a lack of clear evidence, it is very, very important for us as gynecologists to know and understand which exercise is to be prescribed. So we have to consider everything before prescribing exercise in pregnancy. Physical activity is the 4th leading risk factor for early mortality worldwide. So physical inactivity is something that we do not accept. I'm sorry, am I audible?
Yes, Erika, go ahead.
So let me go through the benefits of exercise in pregnancy. First of all, there's a higher incidence of vaginal delivery. We all know the complications associated with cesarean sections, and everybody would ideally want a vaginal delivery, an uncomplicated vaginal delivery. And if you are moving throughout your pregnancy, there is a very high incidence of that. There's a lower incidence of excessive gestational weight gain, gestational diabetes, gestational hypertensive disorders like preeclampsia and eclampsia, low birth weight, preterm birth, and cesarean birth. So what are the anatomic and the physiologic aspects of exercise in pregnancy? So what all happens to your entire cardiorespiratory system as well as your entire reproductive system? So first of all, definitely everyone knows, all of us know that there is weight gain. There is increase in blood volume. The ejection fraction is increased to about 30 to 50% when you're pregnant. There's more blood that has to go to the baby. So naturally there is more blood volume. Heart working much harder because heart rate because the blood has to reach to the baby, hence the heart rate is high, there is less pulmonary reserve, there is less vascular resistance, and the center of gravity is shifted. So because there is a huge baby bump in front of a woman, the center of gravity is shifted from hers to a little bit forward. So all this will come into effect when a woman decides to exercise in pregnancy. So these are the changes that lead to an increase in the forces across the joints and the spine during weight-bearing exercise. So what happens is a lot of pregnant women, all of you gynecologists who are here, how many pregnant women come and tell you that, madam or sir, I'm having a back pain? Almost 60% of pregnant women experience a lower back pain. And this particularly can be avoided by strengthening the abdominal and the back muscle, and it minimizes this risk. So pregnancy changes how the body tolerates exercise also. So it is very important that you tell your patients that she is not going to feel the same the way she felt while exercising when she was not pregnant, because once you start exercising with pregnancy, there are a lot of issues that come. There's loss of balance, there's less stamina, less joint integrity, difficulty in breathing fully, faster heart rates, more perspiration, more sweating, they feel very, very hot. So it is so important that we tell them that all these will happen and all these are normal things to happen, so that they do not give up on it because they are scared that something is wrong. So how do you regulate body temperature when exercising during pregnancy? They feel extremely hot. If you've had pregnant women in your house, you would know that they feel very, very hot all the time, because that's a natural physiological process. So they can stay well hydrated. Avoid any heat and humidity. There is no need to exercise in excessive heat. And wear loose-fitting clothes and probably work out in a cooler environment. Nutritional guidelines, general nutrition guidelines, I will not go in details about this in this, but during the course of pregnancy, the metabolic energy demand progressively increases with the increase in weight. So it is very important that they eat right. You have to do a medical evaluation before prescribing exercise. So the obstetricians and gynecologists and other obstetric care providers should evaluate the women with medical or obstetric complications very carefully before making recommendation on physical activity. This lecture, I am not taking to tell everybody that every woman should exercise in pregnancy. No, you have to, as a doctor, evaluate who you can prescribe the exercise to. There are absolute contraindications to aerobic exercises during pregnancy, which include hemodynamically significant heart disease, restrictive lung disease, incompetent cervix or cerclage, multiple gestation at risk of premature labor, persistent second or third trimester bleeding, placenta previa after 26 weeks of gestation, premature labor during current pregnancy, ruptured membranes, and pregnancy-induced hypertension. I request everybody to just take a screenshot of this, post it in your clinics. These are the absolute contraindications. You can say no to exercise when these are there. There are a few relative contraindications where what I mean by relative is you assess each patient based on their examination and their blood test. Things like severe anemia, chronic bronchitis, morbid obesity. It's very difficult for these patients to exercise sometimes because they'll have breathlessness, they won't be able to move properly. So it depends. You have to take a call when you see these patients, whether you want to or you do not want to prescribe exercise based on their current physical conditions. The precautions is, a few precautions is, avoid exercise in a supine position after first trimester. I will come to that later. Avoid prolonged standing, and heart rate 1.40 is allowed. Why I'm writing it is that we were under this impression that you cannot let your heart rate go up, but The ACOG guidelines and the NHS, the UK guidelines, all of them suggest that it is okay for the heart rate to go a little above for a shorter period of time. I will again come back to the details of that sooner. So you also have to tell a woman, when you're prescribing exercise, you have to be very detailed, like you prescribe a medicine. When you prescribe a medicine, you tell them how many times a day, when do you take it, after food or before food. That is exactly how you should give an exercise prescription. We as gynecologists cannot tell a woman, okay, you're pregnant, you can go and exercise. No. We have to tell them what are the warning signs, like how for every drug we give them a side effect. We have to give them warning signs. These are the signs if a woman who is pregnant and exercising experiences these signs, she must stop at that very moment. These signs are vaginal bleeding, dyspnea before exertion, dizziness, headache, chest pain, muscle weakness, calf pain, preterm labor, decrease in fetal movement, or amniotic fluid leakage. So there are rules for athletes, so that you will always have two kind of women. One who has been exercising all her life and is now pregnant, and one who has not been so active but now wants to be active during pregnancy to avoid complications. So when you have athletes who have been training, who have been playing a sport, and they get pregnant, it is not prudent to say no to them. There are certain rules that you must follow while prescribing exercise to them. They are continue the same exercise only if you were doing it before conceiving for a considerable period of time. Do not try anything new after getting pregnant. Do not increase the intensity or frequency of workouts. Learn about the warning signs in pregnancy. Drop down the intensity of your workouts to about 20 to 30% in the third trimester. Be regular with your vitamins and ensure adequate nutrition. Coming to fetal response to maternal exercise, I would like to tell you that most of the potential fetal risks are hypothetical. Nothing has been proved yet. So do not believe in any of that. Please go through all the evidence that is available before prescribing it. Coming to maintaining supine position, which I mentioned earlier, what happens is in the second trimester, when a lady lies down, the pressure of the uterus goes on the venous system. So maintaining a supine position during exercise after 20 weeks of gestation may result in decreased venous return due to aortocaval compression from the gravid uterus, leading to hypertension, and these hemodynamic changes should be considered when you're prescribing modifications in pregnancy. So whenever you are prescribing exercise, it has to be trimester based. You cannot give a program to a woman for her to do it for all 9 months. Each trimester is a different exercise. So consideration should be given to the type of the exercise, to the intensity, as well as to the duration and the frequency of exercise sessions based on each trimester. Special populations, women with diabetes, morbid obesity, or chronic hypertension. As we know, they all will benefit a lot with exercise, but we have to have individualized exercise plans for them. So when the question exists regarding the safety of aerobic exercise in pregnancy, you should consult certain specialists and subspecialists. What are the examples of exercise that have been extensively studied and found to be absolutely safe and in fact more beneficial is walking, stationary cycling, aerobic exercises, even dancing, resistant exercises using weights and elastic bands, stretching exercises, and all the hydrotherapy exercising, including swimming and water aerobics. So when I say that we have to prescribe, it's not fair for us gynecologists in this day and age to tell a woman go exercise. So many times we are scared because we think they will go to a gym and they will get themselves injured or there will be a harm to a baby. So it's the time for us to learn how to give an exercise prescription. So how do you give it? So give a strength and training workout for 30 to 50 minutes per session. This should include a dynamic warm-up, some breathing work, and some foam rolling to release the tight muscles, a moderate intensity cardiovascular workout. Always have compulsory restorative work or active recovery as often as possible. And this active recovery includes a light walk, yoga, meditation, deep breathing, etc. So when you come to first trimester, what are our goals in exercise? Maintain an optimal posture and alignment, increase the strength and maintain or improve body composition, strengthen the core, develop a solid aerobic foundation, promote healthy levels of body fat, and yield health improvements without overstressing the body. Coming to second trimester, the belly will start increasing, so minimize front-loaded exercises, including push-ups and front plank. Prefer roll in and roll out. Don't jerk into an exercise. Slowly get into and get out of it. Exercises to reduce pressure on your anterior core and reduce high-impact exercises because they can cause injury. Coming to third trimester, generally a woman feels a little more tired than usual, so cut back on the high-intensity training, reduce high-impact exercises because they may cause injury, increase the rest time outside of workouts, reduce your amount of high intensity, and know proper positioning. So there are exercises that are designed to get your body into good posture. So in third trimester, the entire focus is on prepping the woman for birth. So what are these birth prepping exercises? 5 of them: body weight squat, supported deep squat, clamshells, scapular wall side, and inversion. All of these are available on YouTube to be done in a safer way. I will go through them very quickly because we're running short of time, but I will request everybody to download these and keep it. It is so essential for you to teach this to the pregnant women that you are treating, because it is better that a doctor, a gynecologist teaches them rather than them going and learning it from somewhere and getting injured. So these are a couple of exercises where she can wear a band and walk. She can just adductor rock, bird dog where they lift one leg and the opposite arm, cat and cow, which is very, very important for spinal posture and the pelvic health. Open book, all the entire thoracic mobility, clamshells, and just opening and closing the knee. So I will just quickly go through all this because, sorry, we're running short of time. But I want to talk a lot about Kegels. So as a gynecologist, how many times have you told our patient, do your Kegels? Do it 4 or 5 times a day. Have you ever taught them? Do we know if they're doing it right? So what happens is a lot of women who try to do Kegels actually bear down on the pelvic floor, like how we do it in a Valsalva. So it is very important to show, keep a picture of this in your clinic. Show them what is a pelvic floor. What do you mean when you tell them to do a Kegels, and how do you contract it? So I'm going to quickly tell you the right way to do a Kegel exercise is it has to be connected with the breathing. It has to be, when they are asked to inhale, they have to relax the pelvic floor, and when they exhale, they have to contract the pelvic floor. I'm going to quickly show the video where if you see the belly of this woman, when she is inhaling, you have to pull the belly inside and pull the pelvic floor, push the pelvic floor down. If all of you are sitting on your chairs right now, you can actually do it and see it. When you inhale it, you can push the pelvic floor down, and when you exhale it, contract it up. This is the right way to do Kegel. So teach them every time they come to your clinic, make them do it in front of you on how to do it. Because when you do Kegels, if you do an excessive contraction of the pelvic floor, or if you push more on the pelvic floor muscles, instead of strengthening it, it will weaken those muscles. Finishing up with postpartum exercise, we have an entire day tomorrow for postpartum and postpartum related issues that we will talk. So I will not take up more time on this, but exercising after your baby is born may help to improve the mood and decreases the risk of DVT, that is deep vein thrombosis, a condition that can occur more frequently in women in weeks after childbirth. In addition to these health benefits, exercise after pregnancy can also help you lose the extra pounds that you may have gained during pregnancy. I would like to finish by just telling everybody, did you know that the tennis superstar Serena Williams, when she was 2 months pregnant, she won the Australian Open competition in 2017. The middle picture is Alicia Montano, who ran an 800 meter in the US track and field nationals in 2014 when she was 8 months pregnant. And the latest, and 1 week back, Lindsay Fletch completes the Olympic trials for Tokyo 2021 Olympics this year while she is 18 weeks pregnant. So yes, this is happening all over the country, and it's high time that we start recognizing it and supporting these women in fulfilling their dreams even while being pregnant. Thank you so much. There is no conclusion, only one conclusion. Pregnancy should not be a state of confinement. Thank you everybody for listening.
Wonderful, wonderful, Dr. Erika. What a beautiful presentation. Underlining the fact.
You must also tell about your US marathon winning. You have only shown 3 photos. I wish your photo should be also there. That when you are winning the US marathon now.
Thank you so much, sir. Yes, and I'm talking this from experience. I ran throughout my pregnancy. I did marathons in my pregnancy when I was 7 months old, and that is why I am able to say this with so much of confidence that if it is done rightly, it is something that we can definitely do it safely. Thank you so much.
Thank you. Thank you for excellent presentation. Erika, thank you.
Thank you so much, sir.
Excellent, Dr. Erika. Dr. Vijayalakshmi?
Yeah. So after that brilliant talk, very spirited, high-spirited and very enthusiastic talk, I think all of us are again now geared up to listen to one more talk by Dr. Meenakshi Deshpande on yet another important topic, very nicely chosen program with such an important topic on the gestational diabetes mellitus. And we know the burden we carry as the country, as the, and especially from this part of India, I think the southern India is also very highly rated as far as the diabetic incidence is concerned. And we will be really happy to welcome Dr. Meenakshi Deshpande to talk on it all the way from Pune. And she is very active with the violence against women. And I think she has a lot of areas of interest overlapping with antenatal screening, critical care, and cancer workup and adolescent clinics. And she has been the IMA Pune Vice President and very active with lots of societies. So over to you, Dr. Meenakshi Deshpande. We are all looking forward to your talk.
Thank you, Chairperson. And am I audible?
Yeah, very much clear.
Yeah, okay, but I cannot share my screen. It's coming, you cannot share your screen. Please, can anybody stop screen sharing?
Erika?
Somebody's, yeah. So, okay, now I will share my screen, yeah. Okay, can everybody see now? Are the slides, you can see the slides? Okay.
Yeah. Move ahead, Meenakshi.
Okay, okay. Yeah, thank you for this lovely topic, Dr. Erika, which is very close to my heart. And also congratulations to the whole IMA team at the outset for the Safe Motherhood Week, which is an innovative concept of involving, all faculties. It is not just the gynecologists who are responsible for a safe motherhood. It is other people, the society people are also equally responsible for the safe motherhood. Lots of thanks to Ketan Desai, sir, patron, President Dr. Jayalal, sir, HSG Dr. Jayas Lele, sir, Dr. Divya Saxena, Dr. Dilip Datta, sir, chairman of Safe Motherhood Committee, and of course, Dr. Arika Patel and Dr. Ravi Wankhedkar also for thinking of such a concept. And I was very much glad of meeting Dr. Shanta Kumari Madam, our President Foxy, and Dr. Preeti Kumari Madam also yesterday at the time of inauguration. Formally, I'll just start with a little bit of a slide, because now when the religion was strong and the medicine was weak, men mistook magic for medicine. But now when the medicine is strong and religion is weak, men mistake medicine for magic. So they want to stop medicine and go in for magical therapies. And that is where we lack now. We have to control that now. So why this GDM? Why is it such an important topic? Why this has come up in the recent years? It was not there 10 years back, 20 years back. But look at the prevalence. If the diabetes is poorly controlled, yes, it has got a 10% chance of birth defects, 5 to 10% chance of women having problems, and 3 to 4% chance of maternal mortality and fetal mortality because of traumatic labor. And look at the prevalence of GDM in India. 3.8% in Kashmir, 35% in Punjab, 17.9% in Tamil Nadu, and 15 to 19% in Karnataka. So the prevalence is increasing. Abhi, it is the zamana badal raha hai. It is not only undernutrition which is causing problems. Now it is overnutrition. And just as rightly Dr. Erika has mentioned in the previous presentation, physical inactivity is creating problems now for the would-be mothers. So much more common than you think. And most importantly, it is easily preventable. Think of this. There are more than 1 million cases per year now. It has got no symptoms, no complaints. But yes, it requires a medical diagnosis. It requires a thinking. It requires the screening by a doctor as of a patient. And it is completely treatable by any medical professional. Lab tests and imaging are required. And with medium-term treatment, it resolves within months. So just gestational diabetes conditions is always associated with persistent metabolic dysfunction in women 3 years after delivery. So why this is gaining importance is that diabetes is not only associated with complications during pregnancy, but is also associated with long-term complications of the health of the woman. Now, diabetes in pregnancy can present as two different conditions. Either it is a pre-existing diabetes, which is coming to you and patient becomes pregnant on that pre-existing diabetic condition, or patient comes as a gestational diabetes to you, which is called as a true GDM. Now we first start with a de novo gestational diabetes, because both these diabetes have got a different spectrum of treatment managements and concepts. Gestational diabetes is defined as any degree of impaired glucose tolerance with onset at first recognition during pregnancy. Remember that it is about 7% of all pregnancies, and the range of prevalence is from 7 to 14%. Remember also that the 15% of GDM remain diabetic after the deliveries and the pregnancy and the postpartum period is over. And 50 to 60% of these GDMs will become diabetic in the next 5 to 10 years of life. So when a patient asks you or any practitioner as of IMA, what is gestational diabetes? It's a diabetes which occurs in pregnancy in women who never had diabetes before. And it is normally because of improper movement of glucose from the cells to the tissues. And this is because of the insulin resistance. What are the fuel mechanisms in pregnancies? The main goals of fuel mechanisms in pregnancies are to develop a proper millennium for the fetus to grow. In early pregnancy, anabolic stores are developed to meet the metabolic demands in the late pregnancy. In late pregnancy, much more fuels are encouraged and are gathered for fetal growth and the energy needs. So the glucose metabolism in pregnancy differs in early pregnancy and late pregnancy. In early pregnancy, there is a tendency towards hypoglycemia because of increased utilization, and 10% fall in the blood glucose levels are seen because of even, you can say, problematic intake of the patient. But as soon as the pregnancy, nausea, vomiting, NVP tends to decrease, in later pregnancy, there is a tendency towards hyperglycemia. Increased insulin resistance and hyperinsulinemia, of course, with the concept or with the help of the hormones secreted by the placenta, especially the HPL, the placental growth variant, the cortisol, increased fat deposits during pregnancy, all seem to mediate insulin resistance. And insulin sensitivity also decreases progressively during the third trimester. All these give rise to a hyperglycemic state in the late pregnancy. Sorry for this slide, but just this is an concept that GDM is characterized by hyperinsulinemia and insulin resistance, and that leads to an abnormal carbohydrate metabolism. Now, this concept of sugar, is it so harmful to the pregnant woman or to the society that it needs to be screened, it needs to be tested, it needs to be treatment? But yes, now we go to the facts of GDM. GDM normally occurs after 20th week of gestation, and this proper de novo GDM is not associated with increase in anomalies, but it is associated with increase in the size of the baby. That is a macrosomia. It is also associated with increase in the incidence of abortion, increase in the hypertensive disorders, polyhydramnios, and macrosomic problems for the mother, because macrosomia can lead to traumatic delivery. Remember, shoulder dystocia and all the third and the fourth degree vaginal tears during pregnancy occur because of a big and an unaccustomed size of the baby's head. At the same time, the infant risks are that birth trauma, shoulder dystocia, you can get fractures, you can get nerve palsies, you can get pulled out of the, clavicles are pulled out, fetal death. And that is why we have to keep a watch on the sugars of the baby as well as the mother, same as after 14 to 15 weeks of gestation. These are the macrosomic babies, and they go beyond 3.8 to 4.5 kg. What are the mechanisms why these babies become macrosomic? Remember, any high blood glucose levels, a persistent high blood glucose levels in mother brings extra glucose to the baby. And this extra glucose, again, the baby starts functioning and putting on insulin and causes extra fat deposition in the baby's tissue, which becomes a macrosomic and a polyhydramnios. So again, we used to have arguments some few years back, whether GDM is a disease. Yes, workers used to say that there's a twofold increased risk for pregnancy-induced hypertension, macrosomic incidence raised to 40%, significant increased risk of dystocia, and increased admission to NICU. There were trials, there were randomized controlled trials trying to prove that GDM is a disease and its screening, testing, and management is beneficial to the woman to reduce the mortality and morbidity. Of course, you should also remember the vicious cycle in which obese woman giving rise to an obese child. Again, the same epigenetics continue, and you get a vicious cycle of the baby becoming a young mother in obesity, and again giving rise to a PCOS, obesity, and a GDM in her next pregnancy. So if you have to cut this vicious cycle of diabetes, we have to somewhere screen the patients for GDM and stop it and prevent it there and then. So how do we do it? What are the indications? What are the risk factors? Now, these are the risk factors in which normally we have a previous history of macrosomia, previous history of diabetes mellitus, age of the mother is more than 30 years. We have got a little bit more risk. By BMI, that is obesity, more than 30 gives rise to a threefold rise in the GDM. A change in the interpregnancy weight, just see, by 3 BMI, if the previous pregnancy was normal, but an interpregnancy weight is increased by 3 BMI, there's a twofold rise in the GDM. Certain ethnic groups, races, history of smoking in the mother, history of previous PCOD or hypertension, pregnancy-related hypertension, history of spontaneous abortions, unexplained stillbirth, a strong family history of diabetes, a persistent glycosuria. All these are the risk factors for a pregnant woman to develop gestational diabetes in this pregnancy. So what about the screening? These are the warning signs, but they are not available. They may not be there in the early signs, may not be there. No symptoms. Remember the last sentence. No symptoms may be there for gestational diabetes. Patient may be just happy roaming about here and there. But who do we screen in? Do we screen all mothers, or do we screen only these at-risk mothers, or you can say selective mothers? But on many studies, it has been found that only if we screen for high-risk mothers, 45% of such GDMs will remain unscreened, and we may miss 30% of gestational diabetics. So at least for Indians, we are recommending universal pregnancy testing for screening for gestational diabetes, along with DIPSI at the first antenatal visit, again at 24 to 28 weeks, and again at 32 to 34 weeks. Now, why separate guidelines for Indians? But remember that Indian females are at 11-fold increased risk of GDM than Caucasians. Prevalence in India is, I told you in the beginning, it's about 15 to 16%. Universal screening detects more number of GDM, and single blood glucose measurement after glucose tolerance is economically feasible, more patient compliance, and that is our DIPSI, which are the major things which they give, and the major tests which are being given. So Diabetes in Pregnancy Study Group of India, that is the full form of DIPSI, has suggested, and it has proved, that any time a pregnant woman walks into an antenatal clinic, she can be given a 75 grams oral glucose load, and after 2 hours exactly, a venous blood sample is taken for estimating plasma glucose. Such a simple test and a blood sugar level more than 40 milligram is gestational diabetes. This recommendation is to be done, this is to be done between 24 to 28 weeks of gestation. And all this is supported by World Health Organization, DIPSI, IAD, PSG, that is International Association of Diabetes and Pregnancy Study Group, and the American Diabetes Association. All support this 25-gram one-step testing, and also the use of a hemoglobin A1C at the first visit. What is the role of hemoglobin A1C? Now, hemoglobin A1C, if you do it before 20 weeks of gestation, and if you find it on the higher side, remember that that can be a pre-pregnancy diabetes in pregnancy, which has to be controlled and treated. If the pregnancy is, HB1AC is borderline, that is 5.7 to 6.4, you can just counsel on diet and monitor her blood glucose in future days of pregnancy. But if she is less, then you have to remember that she is a plain GDM, because hemoglobin A1C will tell you the past glucose control of the patient. So the IAD PSG guidelines recommend that GDM screening has to be done between 24 to 28 weeks of gestation. 75 grams 2-hour OGT can be used later on, but plasma glucose more than 92, 1-hour plasma glucose more than 120, 180, and 2-hour plasma glucose more than 153 has been recommended for the diabetic screening and diabetes checking. But the DIPSI criteria, and which is applicable for our Indians, is remember normal is less than 120. 2-hour plasma glucose after 75 grams of the single glucose challenge test should be less than 120. If it is between 120 to 139, it is gestational glucose intolerance which has to be followed up. 140 to 200, it is gestational diabetes mellitus. And more than 200, it is overt diabetes. I would recommend you to take a screenshot of this slide and keep it with you because this is the most important slide of this presentation. DIPSI criteria is very important for every one of us to know and follow in our clinics whenever we are seeing any pregnant patient. Now, why this GDM? You can see the lower part of the slide in which 11,789 pregnant women in Tamil Nadu were tested over 6 to 8 months in 2014 using these criteria. And you can see how many of them were detected positive. In the first trimester, out of 4,300 pregnant women, 233 were detected as GDMs. In the second trimester, 4,632. Out of these patients, 320 were detected. In the third trimester, 187 were detected positive for GDM. So we have to manage GDM, and our primary goals is to prevent microsomia and maternal and fetal mortality and morbidity. So control should be like this. And what are the main recommendations is by diet, setting a goal for pregnancy weight gain, reducing the size of food portion, as well as exercising in pregnancy with a minimum of 30 minutes exercise on most of the days of the week. Dietary management, yes, we have all know. I'm not going to go into much details because this was a prevention of GDM. So we have to have a controlled weight gain of the patient. We have to have a proper exercise regimen and a proper dietary plan. The proper dietary plan will include gestational diabetes diet chart. You can go through how much total fat, total calcium, total iron, total protein, and the proper dietitian can give you a good advice. You can also go in for a caloric distribution. See, the caloric distribution is 10% of the diet for breakfast, 20 to 30% of the caloric for lunch, 30 to 40% for dinner, and remaining 30% for snacks in between. And the weight gain should be monitored very carefully if you don't want to have the patient to go into overt diabetes. Glucose monitoring, of course, should be done with a glucometer. Daily monitoring is very important for a mother. Fasting blood sugar level is very important to determine the preconception diabetic programming. Postprandial sugars are most predictive of microsomia. And the most difficult glucose to control is the post-breakfast, that is a dawn phenomenon, because if they become uncontrollable, they are the most normal indicators or a proper indicators of fetal demise. So GDM, you have to manage with your comprehensive treatment. And the last of all is the medication. When will you initiate pharmacotherapy for a gestational diabetes? Only when your goals exceed more than twice GDM of A1 to A2, 2-hour postprandial sugars increase more than 120, the morning fasting sugars increase more than 95 to 100, and on sonographic imaging, the fetal abdominal circumferences increase more than 70% at 29 to 33 weeks. So at this stage, one has to consider and think of starting medicine. So these are the other treatments for medical management, which I will skip. Now, when we have come to the pre-existing diabetes with pregnancy, how do you go about thinking? Pre-existing diabetes is when patient has already, she is on anti-diabetic medicines and she wants to become pregnant. And such cases are also increasing nowadays in our society. But these have got a different sort of metabolism of glucose. In the fasting stage, they have accelerated starvation, exaggerated ketosis, whereas in well-fed stage, they are severely hyperglycemic, hyperinsulinemic, and hyperlipidemic. So we have to think about these complications before we treat diabetes and wanting to become pregnant. First trimester will be malformations. So we have to think about that uncontrolled diabetes, uncontrolled high sugars are teratogenic because they give rise to maximum harmful fetal malformations, which are not very comfortable for the patient to live. Congenital abnormalities in a high blood sugar level milieu of the mother is very important. Now see how this age-wise conception to 8 weeks, the malformations go on forming. Caudal regression is seen at 3 weeks, neural tube defects seen at 4 weeks, cardiac abnormalities can be seen or start at 5 weeks, renal abnormalities and GI at 5 and 6 weeks. And from 8 weeks onwards, we have got other like chronic hypoxia and intrauterine death, microsomia and others. So this is the chart you can see follow whether the absolute fetal anomalies increase as the hemoglobin, periconceptional hemoglobin A1C increases. This is a very important chart. Again, you can have a screenshot of this and keep it because this is totally preventable by any practitioner in India. Every practitioner in India should know this, and how we can prevent this is in my next slide. The most characteristic abnormalities you can see are the cardiovascular abnormalities. The most common is the ventricular septal defect. The most common characteristic is the transposition of the great vessels of, that is the TGA. The second most common congenital anomaly which we can see with gestational diabetes are neural tube defects like anencephaly and spina bifida. Characteristically associated with diabetic embryopathy is caudal regression syndrome and sacral agenesis. So the most useful test and important test is hemoglobin A1C, which you have to do preconceptionally, periconceptionally, or immediately after conception if you suspect patient can be having a little bit of a high sugar. These are the tests we can differentiate you from gestational diabetes, type 1 diabetes, and type 2 diabetes. What are the maternal complications for this? Is a worsening retinopathy, worsening proteinuria, hypertension and cardiovascular disease in the mother, neuropathies, and many infections. So what is the preconception checklist for the woman with pre-existing diabetes for her to go into a pregnancy without diabetes or a controlled diabetes? Is using a reliable birth control until she gets an adequate glycemic control. This is very important because we don't want unplanned pregnancies for her diabetic patients who are trying for pregnancy. Attain a preconception hemoglobin A1C below 6.5. She may have to change the medicines of metformin and glyburide are allowable in pregnancy, but other antidiabetics have to be changed. Other diabetic complications have to be looked into and have to be changed, managed. Folic acid preconception for 3 months along with multivitamin, multimineral, and discontinue potential embryopathic medications like ACE inhibitors, ARB, or statin therapy. Receive preconceptional counseling that includes optimum nutrition, optimum diet, and optimum BMI. Optimum BMI should be achieved before the patient becomes pregnant. Supplementation with multivitamins and folic acid is very important. Achieving diabetic control, glycemic control is the fourth important point. Fifth is this anti-hyperglycemic agent should be switched to insulin prior to conception because there are no safety data for the use of other anti-hyperglycemic agents in pregnancy except metformin and glyburide. Women with albuminuria and CKD should be followed closely for the development of hypertension and preeclampsia. Also, an ophthalmological examination is very important for retinopathy, whether she is level 1, grade 2, grade C. And retinal surveillance during pregnancy is very important with a vision care specialist for a pre-existing retinopathy and a poor glycemic control. So again, one pre-pregnancy evaluation chart of what should be done before pregnancy should be managed before pregnancy, before the patient gets pregnant, and major malformations are directly proportional to the hemoglobin A1C levels in the first 10 weeks of pregnancy. Remember, wherever our mothers go to our practitioners in the second stage of pregnancy, second trimester of pregnancy, first 3 months they usually take at home. And this is where we have to do social awareness programs that any patient who wishes to get pregnant, if she comes preconceptionally to any practitioner, we have to give this sort of an advice for the patients if they are looked to be as a high-risk patient for getting gestational diabetes. This is an oral hypoglycemic agent which only 2 can be used and can be continued, but mostly insulin is preferred because diabetic agents, medicines, drugs are not reliable. So this is my final slide, that what we can achieve to prevent all this. We have to prevent, because 5.7% develop type 1 diabetes within 7 years, 50% develop type 2 diabetes within 23 years, and the use of insulin therapy is the greatest predictor of future diabetes. So prevention is better than cure. And target, this is again an important slide which you can just photo and take it. Keep the fasting and before meal less than 995, keep 2 hours after meal less than 120, and hemoglobin A1C less than or about 6. And this target, if we achieve throughout pregnancy with a good diet, yes, we can get a thank you from our next generation, and we can have an active and a non-obese next generation. So thank you all for a patient hearing.
Thank you. Thank you, Dr. Meenakshi. Wonderful presentation from basics comprehensively.
Thank you.
How we need to really focus ourselves into prevention for further diabetic control and management, so that we can see some end of the tunnel in this long tunnel which you have been traveling for the gestational diabetes, so that further generations are also not really into it. And I have seen some questions where they are asking whether, apart from genetics, does the epigenetics also play a role?
Play a role, very good.
Yeah.
Yes, yes.
Yeah, definitely epigenetics, to my knowledge, also plays a role. Meenakshi, do you want to add on to that?
Yes, I feel so, because it is epigenetic only which gives rise to a glucose intolerance. It is genetically based also, why some people get glucose intolerance and why some people don't get. It's like getting an obesity for any teenager also.
So,
hello.
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 Thank you so much, ma'am, for a wonderful lecture, and I really thank my 2 excellent chairs.
And of course, when we are talking of GDM and all, I think the fetal origin of the adult disease is so much.
Yes, that is very important.
Erika, go ahead.
Thank you, Dr. Vijayalakshmi Seshadri and Dr. Bal Inamdar for sharing these wonderful sessions. And I request all of you to come, because pregnancy, as we know, does not end with the delivery of the baby. There is a lot that a woman goes through even in the postpartum period, and that is what we are going to address tomorrow, about how we can help women to have a safer postpartum. I request all of you to come tomorrow and join us there.
I thank everyone for this opportunity. Thank you, Dr. Datta, and thank you the entire Dr.
Thank you, sir.
Thank you, our National President, Dr. Jailal sir,
and
Dr. Vinay Agarwal sir, Dr. Ravi Vanche. A lot of IMA leaders that have been here with us. Thank you so much, sir, for supporting.
Yeah, thank you. Thank you, Dr. Dilip Kumar Datta. Thank you, Dr. Erika. Yeah.
Dr. Erika. Thank you, President, sir, for being here.
And thank you, chairpersons, Dr. Bal Inamdar, and
Yes.
Tomorrow, the Women of Feminine.
Great, all the best. We will meet tomorrow also.
Yes, sir.
Yes, sir. Thank you.
Thanks.
Thank you.
Tomorrow,
Thank
the
you.
Women of Eminence is also a very interesting personality. Mrs. Harika, I think you will have a very interesting session with her. She is the political editor of Times Group. The profile is so interesting, so you will have a very interesting session. So I request you all to join tomorrow.